Welcome everybody to the UCSF Bay Area Breast Cancer Forum, where we're here to do an American Society of Clinical Oncology update with my fabulous colleagues. And the Breast Cancer Forum here is open to anybody who's interested and is coordinated by the excellent, who just disappeared, Melody Galu, who maybe will come back and just wave at you. And she does a great job and is the person who accesses the email, which is listed there, Bay Area Breast Cancer Forum at ucsf.edu. And you can also see the website, cancer.ucsf.edu/forum. And that will, if you use your QR code there, you can save it if you want. But that will also take you to podcasts of our programs if you're interested in listening again or sending it on to someone who might not be on. So on your screen, you can see that there is a Q&A button on the bottom, and that's where you should put questions for us because we can answer them as we go along, and we can also answer them in the Q&A portion of each section. But anything that pops up into your mind, just pop it into that Q&A box that you can click on the bottom of your screen. We don't use the chat function for the Q&A because we can't respond as well to that. Now, I'm Hope Rugo at UCSF in the breast cancer program, and I'm joined by an all-female group of breast cancer oncologists, although we do have some men in our group. And I have Michelle Melisko, who has the bridge behind her there, but it's blonde compared to Laura Huppert. So Michelle Melisko. Laura Huppert, who's our newest faculty member, who just joined us after having spent her fellowship working with us, and we're really excited to have her. And then Chien, who I think you also know very well from previous forums. And everybody in our group has a little bit different focus in terms of our research work. We all work together clinically and interact all the time about how we manage new information and translate it to our patients. So that's what we want to do now, is to tell you a little bit about the exciting areas that we heard about the American Society of Clinical Oncology. It's important to keep in mind that some of this is developing data. It may not be definitive. And if you don't understand something, definitely put a question into the Q&A box. So, and then, our Bay Area Breast Cancer Forum will start again in September, October, et cetera. And somebody has asked about new data for triple negative breast cancer, and you'll hear about it as we go along. So we're going to start with a couple of presentations that Chien will talk about, who then will be participating as she travels home quite far from the cancer center. And then we'll go on to the next presentation. So Jo, you're on.
Thank you. So I'll share my screen. Okay, hopefully everybody can see that. Mm-hmm. All right, so I'm going to sort of take off my medical oncology hat for just a brief moment because I'm going to present a really interesting and exciting abstract related to radiation. This trial is called the Lumina trial, and the purpose of this trial really was to ask, is there a group of patients that have low enough risk of local recurrence that we can omit radiation after surgery for early breast cancer? Oops, okay. And just a couple slides on background. We know that after lumpectomy or breast conserving surgery, that we can reduce risk of local recurrence, meaning a recurrence in the breast or the regional lymph nodes. And on average, we can reduce risk by 67%, and that's a relative risk reduction. But of course, there's significant toxicity that comes with adjuvant radiation. That includes skin irritation, redness, fatigue, pain, swelling, and it can alter the cosmetic outcome. And then there's small risks of heart disease and secondary cancers. We also know that historically, we're not perfect at predicting who has small enough risk and can avoid radiation just based on clinical and pathologic criteria. And one of the issues is, how do we define low risk? And historically, this is based on how big the tumor is, whether lymph nodes are involved at surgery, how old is the patient, the ER status, the HER2 status, and the grade. And more recently, there's been a lot of interest in looking at the biology of the tumor. Can you add the molecular profiling? And one of the ways we do that is looking at something called intrinsic subtype, where we look at gene expression. And that can be with protein, this could be done with RNA, where we have grouped ER positive cancers into different, what we call intrinsic subtypes. And what this group aimed to do was use the intrinsic subtyping along with the classic clinical pathologic criteria of size, nodes, age, receptors, and together define a group that is low enough risk of local recurrence where radiation can be omitted. And this is a study that looked at intrinsic subtyping and looked to see how they relate to local risk reduction, local risk of recurrence. And there is a group called luminal A. These are the sort of slow growing ER positive, tends to be our lower risk tumors. And when they grouped them based on their gene expression and called them luminal A, the 5-year risk of recurrence was only 2.8%. And that is very low in this field. And so using this way of classifying tumors as luminal A, along with clinical factors, this group identified a group of patients where they said, after surgery, patients will get hormone therapy, but no radiation. I wanted to find out what is the risk of local recurrence over 5 years. And they defined low risk as less than 5% risk of a local recurrence at the 5-year mark. Now, a group can arbitrarily decide what is low risk, but for this trial, a very low risk is less than 5% of patients having a local recurrence without radiation and only hormone therapy at the 5-year mark. And they wanted to see if they were able to select this group of patients using the clinical and the luminal A factors. So that's what they did. They included patients that were 55 years or older. In the past, these types of trials looking at whether we can omit radiation were done in older patients, initially 75 and older, and more recently 65 and older. So this trial brought that age down to 55. Patients must have tumors that are less than 2 centimeters. ER must be positive, PR at least 20%, HER2 negative, and they must have had lumpectomy and a sentinel lymph node biopsy with negative lymph nodes, and patients must take adjuvant hormone therapy. And then they went through some additional testing. So they wanted to enroll patients that had a lower Ki-67, which is a marker of proliferation. And if they met all of these criteria, they were allowed on study. And this is just another slide summarizing what I just said. So really selecting for our lowest risk clinical patients that are meeting criteria for luminal A type cancers. And all these patients must have had endocrine therapy. Any endocrine therapy was allowed, and they were followed every 6 months for 2 years with mammogram. Well, 6 months for the first 2 years with mammogram, and then mammograms every year. And here it shows the breakdown of the patients. The majority of patients were about half were 65 to 75, and 40% were 55 to 65. The majority of patients had tumors between 0.5 centimeter and 2 centimeters. Almost all the patients were between 0.5 and 2 centimeters. And these were grade 1, grade 2 tumors, and half the patients, or I'd say 60% had AI and 40% had tamoxifen. And what they found at 5 years was, in fact, this group of patients had a very low risk of local recurrence. Remember, none of these patients had radiation. They only had the hormone therapy. So they met this group, this trial met its primary objective and felt that they were able to identify a group of patients that had low enough risk without radiation. And this table, again, is just to show you that the local recurrence risk was 2.3%, and any recurrence, 2.7%. So very, very few distant recurrences, and really only one death related to breast cancer out of the 500 patients enrolled. So in conclusion, this group were able to show that there is a group of women 55 or older with low risk breast cancer that were under 2 centimeters, grade 1 or 2, luminal A's that had lumpectomy and endocrine therapy alone, no radiation, who had a very low risk of local recurrence at 5 years, and specifically only 2.3% had recurrences. So this was a positive study. That's my last slide for this abstract. And the really good thing about this trial is that they were able to answer this question without a large randomized trial. So that if they could have taken a group of patients and randomized them to radiation or no radiation to really try and get to the a definitive answer. But trials like that for patients that have very low risk takes a lot of patients, a lot of time, and it's really hard to show. This group answered this question using a single arm cohort. We call this a prospective cohort study, where they selected a specific group and followed them and were able to show that they had low risk without radiation. So that's another way to answer this question.
So Joe, let me just ask you a question about this. Nicely done. And really, I thought it was an interesting study, but there was a lot of sort of pushback, I thought, on Twitter, our major medical communication pathway. People were saying, well, what about, endocrine therapy is not such great shake. So what about, why would you just not do radiation and not give the endocrine therapy? And how do you know that people are going to be compliant with the endocrine therapy? Do you have any concerns about that?
Meaning, why would endocrine therapy be preferable over radiation? Is that
right? Why is endocrine therapy preferable over radiation, or do they achieve different endpoints and or complementary endpoints? And the second thing is, would there be a patient where you would have more concerns about omitting radiation who fit into this category?
Right. So remember, endocrine therapy or systemic therapy can help with reducing local risk of recurrence. But primarily, the goal is to reduce risk of distant recurrence, which is, in my opinion, of course, the most important type of recurrence to prevent. And therefore, I would not omit endocrine therapy, whether one does radiation or not. And certainly, I don't think this was meant to be do endocrine therapy instead of radiation. This is saying, hey, can we just define a group of patients who have low enough risk where the toxicity, where the benefit, it does not outweigh the toxicity of radiation. In terms of the second question of, is there a group of patients that I would not be excited about omitting radiation for? Certainly patients who do not fit these criteria, and these are quite restrictive. So under 2 centimeters, node negative. I think when you go beyond that, an ER positive, HER2 negative, if you go outside of that definition, I don't think we can necessarily extrapolate and apply.
Great, thank you.
Sure. Okay, so I'm going to move on to the second abstract that I selected, which is called the Astra study. And this is a Korean study that really asked the question, is there benefit of ovarian suppression with tamoxifen compared to tamoxifen alone in premenopausal women with early stage breast cancer? So as many of us know, this is a very important question that applies to many, if not most, of our young women. The idea that suppressing one's ovaries and making a premenopausal woman postmenopausal plus hormone therapy, is that better than hormone therapy or tamoxifen alone? Because of course there are additional side effects and long-term outcomes associated with early menopause. And We do have other studies that have looked at this. This is the soft and the text studies that have asked this question, and they suppressed women for 5 years. This study is unique in that it suppressed women for 2 years. Okay, so here's the study design. They took all premenopausal women that were 45 or younger. They must have all had ER positive, early stage breast cancer, stage 1 to 3, and they must have received surgery and chemotherapy. After they finished chemotherapy, these patients underwent close follow-up for resumption of periods, because they really wanted to identify patients who remained premenopausal, and then they randomized the patients who remained premenopausal after the chemotherapy. So really selecting for the women who continued to be premenopausal, who were not put into permanent menopause with the chemo. And they took that group of women and there was 1,282, and randomized them to get ovarian suppression with goserelin and tamoxifen versus tamoxifen alone. Of note, this trial did not compare to an arm with ovarian suppression and an AI, which the soft and text trials did. So this is really just asking the question of ovarian suppression alone, with both groups getting tamoxifen. And they continued the ovarian suppression for just 2 years. The tamoxifen was for the standard 5, but the goserelin was just 2 years, as opposed to other studies that looked at 5 years. So these are a sort of a summary of the patients that they included, and compared the patient population to the soft trial that asked a similar question with the 5 years of ovarian suppression. So Astra included 45 or younger. Soft, just had to be premenopausal. They didn't define an age. The median age was similar in the 2 trials, 40 years old, and more than half of the patients were lymph node positive. So that is an identifier for higher risk patients. So that breakdown was similar in the 2 trials. And both trials did have a subpopulation of HER2 positive patients, 14% in Astra and 19% in the soft trial. And again, 2 years of suppression for Astra versus 5 years in the soft trial. And here are their primary results. And what they found was that when they followed women out 5 years, and this is something they reported at a previous study, that the risk of a recurrence or an event related to breast cancer was lower in the group that received ovarian suppression. And so that difference, that benefit with the ovarian suppression was 2.7%. At ASCO this year, they reported out the 8-year follow-up, so longer follow-up. This is their final analysis, and that benefit continued and now is 5.2% in favor of those that got the ovarian suppression. And when they looked at, whether this impacted overall survival, just how long patients lived, there was no difference. And it's really hard to show survival difference in these kinds of studies because you're really just looking at 8 years. And we know that these patients are doing extremely well. So we're really just looking at the difference in recurrence of breast cancer as well as new cancers. And based on this study, it's saying with 2 years of ovarian suppression, we can still see this benefit of 5 years. We see the similar benefit of about 5% in the other studies that looked at 5 years of ovarian suppression. One other thing to note, of that 5.2% benefit, 3.7% was in a lower risk of distant recurrence. The remainder is with local recurrence and new cancers. So to summarize this abstract, the investigators found that there was a 5% absolute benefit in what we call disease-free survival, meaning in recurrence risk, with just 2 years of ovarian suppression added to tamoxifen compared to tamoxifen alone in patients who remained premenopausal after chemotherapy. They were not able to show any survival difference, but again, at 8 years, which shows that these women are doing extremely well, actually, with tamoxifen. Some women will do extremely well with just tamoxifen alone. And then finally, this is saying, okay, well, we previously saw a study where patients had to be suppressed for 5 years to see this 5% benefit. Is it possible that 2 years is enough? I would say that this is a little complicated because we also know that adding an aromatase inhibitor to the ovarian suppression results in even greater benefit in these younger women with higher risk. And we also know that for women to get young women to get an aromatase inhibitor, they must have ovarian suppression. Their ovaries must be suppressed. So even if there is some, benefit with just 2 years, the reality is that for patients who need an aromatase inhibitor where we know it's the most effective and most aggressive hormone suppression, the ovarian suppression must continue if the patient remains premenopausal. So I'll stop there. That is my final slide for the 2 abstracts.
Let me ask you a question, Joe, again, about this this trial, which I thought was really, really interesting. I mean, I think there may be some impact in different patient populations also because, the women who are enrolled in this trial largely have a lower body mass index than women who are enrolled in trials in the more Western world, and that may significantly impact benefits from endocrine therapy. So that was interesting. I thought, for the survival data, it doesn't really bother me because we have great treatments that keep people alive with metastatic disease for longer. So that's good. I think the real question is why the difference in, do you need 2 or 5 years of therapy? And the only data we have is looking at 2 versus 5 years of tamoxifen in postmenopausal women, where 5 years, if you followed the patients out to 15 years, the patients who took 5 years versus 2 years had less recurrence and less distant recurrence. So, we do have some data that duration makes a difference, whether or not you could just do ovarian suppression for a shorter time and then continue endocrine therapy afterwards so you reduce side effects is, I think, really interesting. What do you take on, what's your take on that, and what's your take home message to your patients who have higher risk disease where your, soft and text suggest if you have really low risk disease, tamoxifen alone may be good enough, but high risk.
I mean, I think this sort of, I think that this is showing that for many women with tamoxifen alone actually is very effective. What this study doesn't really address is what we're going to do in our highest risk women, because those women we know from soft and text will benefit most with an aromatase inhibitor, and for at least 5 years of an aromatase inhibitor. And so for those women who remain premenopausal, they have to be on ovarian suppression. So we would have to continue the ovarian suppression for 5 years. So for those highest risk women who will benefit most from an AI, the 2 versus 5 years of ovarian suppression, I think, is less relevant because they have to remain suppressed to get the AI.
And so what do you take back to your practice? So how long are you treating patients with ovarian suppression?
So I will continue the 5 because my highest risk patients are on an AI, right? So I don't think this addresses that, but it is saying that for patients who, honestly, who you are considering tamoxifen alone, right, which probably are patients who have lower risk based on all of the other factors you use to determine risk, may be okay with tamoxifen alone. And the ovarian suppression, if you wanted, if there was some concern, maybe 2 years alone is okay, and then continue the remaining 3 with tamoxifen alone. So I think this for me is really, more informative for the patients who have lower risk. And for some reason you are kind of borderline of, do we do the ovarian suppression or not? But our highest risk patients are still getting AI and ovarian suppression for 5 years.
And if people aren't tolerating AI, you feel comfortable changing over to tamoxifen in that setting?
Yeah, and for those patients, I would continue their ovarian suppression at least for 5 years right now, because I think we know that there's still benefit of ovarian suppression, and then we'll just have to see the 2 versus 5 versus based on how they're tolerating the ovarian suppression.
Other questions that my colleagues might pose you? What are your thoughts, Michelle, on this data?
Yeah, I mean, I think that it is intriguing in that, there are maybe it's just me, but I have a lot of patients that have a really hard time with OS plus AI. And there's also these women, these in their, mid 30s, mid to late 30s, who are really, maybe not ready, that didn't get an opportunity to harvest eggs before they, went into their treatment. And maybe they're at 38 years old and they are thinking, I want to take a break to harvest eggs or try to have a baby. And they can't obviously do that on ovarian suppression. So I'll give, them a break. And it makes me feel a little bit more comfortable, knowing that if I, say to them after they complete their, chemotherapy, or if they just go on ovarian suppression plus tamoxifen for a couple of years, that, it's good to know that a couple of years means something. Patients, I think, can wrap their head around a couple years of feeling a certain way. But thinking about 5 years of feeling, it just seems more, and then, after 2 years, maybe some of them will get used to it, the getting used to the hot flashes and they've kind of worked through it and stuff. So I look at this as a segue that I can say to them, let's try this, let's, start with tamoxifen, add the ovarian suppression, see how you do for a couple of years, and then have a discussion. And at least, you will have gotten some benefit. That's always the question. Patients ask me that all the time. What if I do just 3 years of tamoxifen, or what if I do just 3 years of this? Do I get partial credit? And I think this gives us the idea that there is partial credit.
Right.
So that's my takeaway.
Yeah, no, I love that. And I love the partial credit idea. The Austrian breast and colorectal group trial looked at just 3 years of OS plus AI versus tamoxifen. And they also had a secondary part where they were looking at the bone drug, zoledronate or Zometa. And that trial, a long time ago, people did remarkably well. They didn't get any chemo, so we weren't using Oncotype and Mammoprint and stuff like that then, but clearly you can still make a difference with shorter duration, although we all prefer the longer. And I think the optimal duration of ovarian suppression, we just don't know. Laura, do you have any other thoughts?
Oh, you're on mute.
Muted. There we go. No, I totally agree. And I think that when I think of patients, I often think like, are they more of a patient that should be on tamoxifen, or are they an OSAI type of patient? And I tend not to think of TAM plus OS. And so I think this data is interesting for those patients who are on the borderline, where you feel like they maybe could do TAM, but something, you at least are thinking about the OSAI. And so maybe these are the patients where the TAM plus 2 years of OS could be really beneficial for them without having to go through all of the side effects of the OS plus AI. So I do think it's this partial credit / intermediate pathway that might be best for some patients.
That's interesting. And it is interesting to me. I have had a few people ask me recently again, why am I taking treatment if I had surgery? And, why do I need this? And how do you really know? And all that kind of thing. And maybe we'll have a chance a little bit to talk about cell-free DNA, but we don't really know. And we don't have a good feeling for it. And we base it all on these randomized trials and look at, for patients who have hormone receptor positive disease that are sensitive to hormone therapy, you got to do 15, 20-year follow-up to really know what the true benefit is of the treatment. And this carryover effect of when you stop effective treatment, you're still suppressing recurrence out for several years is really, I think, an important one as well. So you can see that, I think it's all based on risk and the data we have, but we've definitely moved ahead in terms of understanding these benefits more. So really interesting.
I also think it's really interesting when we think about this, this controversy for these ER positive patients, premenopausal, are they getting benefit from the chemo, or are they getting benefit from ovarian suppression, right? This is a separate topic, but when you look at the benefits of ovarian suppression in these trials, it's like 5%. Now, all of the patients in this trial got chemo. So we're not sort of saying, is it chemo or hormone therapy? But the benefit of ovarian suppression in this trial was 5%. And we've seen that 5%, in other trials of ovarian suppression. It just makes me wonder, is it that it's the ovarian suppression that is giving us that benefit that we are seeing from the TAILORx or MINDAC trials?
Yeah, from trials where people have said patients benefited from chemotherapy, for example, in one randomized trial, but using Oncotype, the women received actually inadequate endocrine therapy, right? So they have very high risk disease and got chemo, but most of them just got tamoxifen alone without ovarian function suppression. So it does make it really hard. And now they're doing another trial that's really designed the right way, but it'll take another 10 years to get results from that. So that's tough. It's a really important point. So we can move on, I think, and talk about the next trial. I was thinking maybe we go back and forth. Michelle, do you want to talk about the maintain trial?
Sure. I'll go ahead and go to my start the, oops, sorry. I just did the start from the beginning, which was not what I meant to do.
Well, we can't have yet either.
Yeah, I was trying to get to the beginning of the slides, not from current slide. And now I'm going to share my screen. I'm not very quick on the draw here. So the background for this study, and I think this actually came up in one of the questions that was, what to do after the progression on a CDK4/6 inhibitor. And this is the most, since we know that the CDK4/6 inhibitors have really become the standard of care for patients with, estrogen receptor positive, HER2 negative breast cancer in the metastatic setting is first line. And many patients enjoy a very long time to progression on this agent. But I think every patient in the back of their mind is always wanting to have sort of a plan to formulate, what comes next. And so the trial that really addressed this question was one of the trials. There's several trials that are, going on that are addressing this question, is the Maintain study. This has a very long title. It was presented by Kevin Polinsky at ASCO this year. And basically it looked at taking patients that were on a CDK4/6 inhibitor, largely in combination with endocrine therapy with an aromatase inhibitor, and randomizing them to receive either fulvestrant or exemestane, so and SERD, an injectable SERD, or a different aromatase inhibitor, and to get that with or without ribociclib after they had progressed on a CDK4/6 inhibitor. And this was called the Maintain study. So here's the eligibility criteria. Patients had to have had progression on endocrine therapy and any CDK4/6 inhibitor. Largely, you'll see later on, I think I have in the presentation, that the majority of patients that progressed had been on palbociclib or Ibrance, less than or equal to 1 line of chemotherapy for metastatic disease, and they could have stable brain metastasis. And again, patients were randomized to receive the endocrine therapy. And in the beginning of this trial, it was largely the endocrine therapy choice was fulvestrant, who had previously progressed on an aromatase inhibitor, but then they amended the protocol to allow exemestane, an alternate aromatase inhibitor, if they had progressed on prior fulvestrant. And so they were randomized to receive the endocrine therapy alone, or the plus placebo, or endocrine therapy plus ribociclib. So this is also known as Kisqali. And they were looking at the primary endpoint of progression-free survival, then secondary endpoints of overall survival, clinical benefit rate, safety, and then they also were looking at things like tumor and blood markers and cell-free DNA. And I'm trying to go down, sorry. So the next, so basically looking at the patient population, and again, this is a small study, 119 patients, equally distributed. They did have a pretty high percentage of patients who had de novo metastatic disease at diagnosis. And, perhaps a little bit more, they weren't perfectly matched. There were more of those patients in the placebo arm. They were equally matched in terms of the percentage of patients that had visceral metastasis, and also fairly equally distributed in terms of the patients that had prior metastatic disease. Very few of these patients, prior chemotherapy for metastatic disease. And then over on the right side of the screen, you can see that the majority of these patients, 86 and 87%, had progressed on prior palbociclib. Very few had had abemaciclib, and just a few had ribociclib, which is what they were actually being randomized to. And you can see here that the amount of time that the patients had spent on the CDK4/6 inhibitor in terms of months was 17 versus 15.5, which was actually a little bit shorter than our expected median, based on all the number of trials like Paloma 2 and other studies that have looked at first-line CDK4/6 inhibitor. And so here's the data, the primary endpoint of progression-free survival. And what they found is that patients that were randomized and then went on to just endocrine therapy, which was either fulvestrant or an exemestane, had a median PFS of just short of 3 months. Whereas if you added or switched to a different CDK4/6 inhibitor, ribociclib, in most cases, again, a small percentage of patients had already received ribociclib, you extended that out to over 5 months. So about a 2.5 month improvement in progression-free survival. And if they actually focused on, they looked at progression-free survival at 6 and 12 months. The rates at 6 months were different, by about 16 or 17%. But you also saw a pretty dramatic difference in terms of progression-free survival rate at 12 months, with very few patients enjoying stable disease for a very long time when you switched only the endocrine therapy, but about a quarter of patients who remained stable when you switched endocrine therapy and you switched to a different CDK4/6 inhibitor. And I'm sorry, I seem to have a little bit of delay on my end here.
Happens with Zoom.
Yeah, sorry, I'm just trying to get to the next slide. Okay, so in the conclusion, this was the first trial to show a benefit using ribociclib and switching endocrine therapy after progression primarily on palbociclib as the first line of therapy. As I said, palbociclib was the prior CDK4/6 inhibitor in 87% of patients. They did see a reduction in risk of progression or death, although I don't think they had overall survival, they did not have overall survival data. They saw higher progression-free survival at 6 months and 12 months, and ribociclib and endocrine therapy was demonstrated a manageable safety profile. So, where do I take this? Where do I take this data? I think this is a question that patients bring to me frequently, because if you look at something like the HER2 positive space, before we had all of these fancy antibody drug conjugates, and we had, the tucatinib and other, other TKIs to use for HER2 positive disease, our paradigm had always been that you would continue a chemotherapy and, you would continue the trastuzumab, the Herceptin, and switch chemotherapies. And so patients have often asked, well, is there any value in switching endocrine therapy and keeping a CDK4/6 inhibitor going? I think our bias has been, without any data, to stop the CDK4/6 inhibitor and move on to a different biological therapy. In most cases, it would have been a PI3 kinase inhibitor if they were, a PI3 kinase inhibitor if they were PI3 kinase mutant, or an mTOR inhibitor if, PI3 kinase wild type. But I think this is, somewhat, to me, it was provocative data to show that you can actually, potentially have some benefit from a different CDK4/6 inhibitor. And I think this is demonstrated in some of the data that's already been shown with abemaciclib, where we saw, single agent activity with abemaciclib. There have been certainly case reports and small case series showing, and I didn't pull up any of the slides to show that, but that you can sometimes get some benefit from switching to abemaciclib. And I think people have felt that that was kind of a different CDK4/6 inhibitor because of its being given, continuously rather than 21 days on and 7 days off. So I think this was interesting because we think of ribociclib and palbociclib being more similar. So I'm curious to hear. I actually really thought this data was very interesting. Others, Claudine Isaacs did a presentation on just in general at the end of the session, dealing with CDK4/6 inhibitors and the data on Paloma-2. And I think she wasn't as gung-ho and as impressed about it as I was. And I've gotten the sense that others are not as thinking that this is practice changing in any way. And certainly with 119 patients, I don't think it can be practice changing, but it was intriguing to me. And I think on the heels of the data, that was presented at ASCO about, Paloma-2 not showing a survival benefit, which is a whole other topic, a whole other can of worms. I think people have been beginning to ask the question, are there differences between these CDK4/6 inhibitors? Is there an optimal one in certain settings? So I think it's all, open to discussion.
Yeah, I think this is really such an important question. And one of the things that are very exciting is that this was an investigator-initiated trial, which makes the results, I think, even more impactful in many ways because it wasn't sponsored, although it was funded by a pharmaceutical company. So certainly pharma Novartis, who makes ribociclib, funded the trial, but still they did their own analyses. So it was very interesting, several centers in the US. But, it means that the similarities between the patients are less of the same, right? So there could be more heterogeneity in the populations, and that could create some bias, which is why phase 3 trials are required. So I think we have to take the data that, this is a possibility, but we have phase 3 data with some of the other agents, and we just have to balance toxicity, as you were saying. Somebody has asked if there are similar studies for switching to abemaciclib, and that's the post-MONARCH trial. I have no idea why they call it post, but it is a trial that is right after the CDK4/6 inhibitor. So second line therapy, changing to fulvestrant and to abema, regardless of which CDK4/6 inhibitor you were on in the first line setting. And that's a phase 3 trial that will bring us more definitive information. Another question, I guess, Michelle, I'll ask you is, do you think that this has to do with going from palbo to ribo? It was 80% of the people or so, 86, I think. Or is it really just any switch? How do we know?
Yeah, I mean, I don't, obviously we can't know. I mean, obviously this was a well-designed study. What would have been, I think, the perfect design, what would have been perfect, which often, pharma doesn't pay for these perfect designs, but it would have been fascinating to switch endocrine therapy and keep the, same CDK4/6 inhibitor going, switch both, which is what this trial did, and then switch, and then switch the CDK4/6 inhibitor. So having kind of a 3-arm trial to really know whether it's the switch in endocrine therapy and maintaining any type of CDK4/6 inhibition. So we don't have the answer to that question. Someone, in the chat did ask the question about quality of life. And, we certainly know there is a difference in terms of quality of life between abemaciclib and the other CDK4/6 inhibitors. I think we were all very excited when abemaciclib came along, and we thought, oh, we don't have to worry so much about neutropenia. But, the challenges with diarrhea and, GI upset and that kind of thing is no easy shakes. So I think you have to talk to patients and decide how they feel about that. I don't have a good answer. There is no answer. There's no answer to that question yet.
We did 2 things looking at quality of life with ribo, palbo or abema, which was a survey that Fatima Cardosa from Portugal presented at ESMO San Antonio, I think last year, suggested that people were bothered more by diarrhea than by other symptoms. And although fatigue obviously is a big issue with all of these drugs. And then we did a study which we presented at ASCO looking at trying to compare the patient-reported outcomes because they use the same tools with ribociclib versus abemaciclib. And again, came out that, diarrhea has a bigger impact as we would expect, and controlling diarrhea is really important. So, that's the only thing. It's not a, I would say, prospectively designed program. It's all looking retrospectively and comparing study data sets. And for individual patients, it'd be different. The only study that looked at keeping the CDK the same was the PADA-1 trial, where patients who had developed mutations in the estrogen receptor changed from an AI to fulvestrant, but kept the palbo. And we just can't interpret that really at all, except for that, I don't think you can really interpret it. I'll just leave it at that. So I think that's really hard. I guess my question to you, I could ask Joe, do you feel like you would now change what you would do? And would you change a patient on to receive a CDK4/6 inhibitor, a different one after first-line therapy, rather than going to everolimus, or if they have a PIK3CA mutation, alpelisib?
The short answer is no, if I have another option. I think this second line space is so active right now, not just with clinical trials, mainly with clinical trials, but it's really this space, it's a big question mark. And I think with next-gen sequencing, molecular profiling, identifying targets, certainly if you have a PIK3CA mutation, I think I would try the alpelisib first, and I would also consider clinical trials. if, and a number of patients, there isn't a targetable mutation and they don't meet eligibility criteria for trials. And then we're left with fulvestrant as the second line therapy. If there isn't another option besides fulvestrant monotherapy, I would add the ribociclib. I think even though this isn't a definitive study, I think as long as the patient understands that there's potential additional toxicity and, it may be different than the palbociclib, it may be similar, but I think as long as they understand, it's not definitive, but I would do it over fulvestrant alone. But if there's another option, I would do that over continuing or adding the ribo.
Until we have a little more data. One of the questions that came up was whether or not if you had a really long PFS on the CDK4/6 inhibitor, would that be the kind of patient who'd have a better effect from the second one? And there was some mutation data, although in minuscule number of patients. Laura, what did you think of that? I mean, could you separate that out based on people who have mutations that in their cancer that predict more resistance?
I think the numbers were too small in this study to really know that for sure. But I think that's a really interesting question that we'll need to look into. At this point, I don't think we know if you had a long response on one, if the next is going to have as long of a response or not.
The interesting thing about that data, if I recall it, was when they looked at the percent at 6 months versus 12 months. That the again, these are small numbers, but the difference between the percents of patients with recurrence was greater. The difference was greater at 12 months than 6 months. And I think the idea is that if you look at the patients who maybe didn't have a great initial, as long an initial response to first line, those are maybe the patients that kind of, didn't respond and drop off at the 6 month mark. But if you made it past the 6 month mark, maybe those are the patients that did have a longer response first line, that they would benefit more, and you would see that more at the 12 month mark.
Yeah, and I think that goes along with the people who had, if they had a mutation in the estrogen receptor, we call ESR1 mutation, that tended to go along with other cancer mutations. And those patients we already know have a shorter duration of response to their any line therapy, although they benefit from the CDK4/6 inhibitors like ribociclib or palbociclib or abemaciclib. So that probably separates out that group, looking at the difference between early or late, because the earlier patients have already progressed. And then those are the patients, at least in their tiny numbers, who didn't benefit from the addition of.
Yeah, and that would be because of the endocrine therapy, not necessarily the CDK4/6 inhibitor.
Well, it's probably everything, right? Because don't have a sensitive disease. Hard to know whether you can isolate out an effect there,
Right, but right.
One question was, if you have diarrhea, does it affect the absorption, and how effective abemaciclib is? We don't really have any data.
Yeah, I don't think we have any data on that.
Generally people don't continue on the drug if they have horrible unremitting diarrhea. So that gets rid of that problem. But we generally have found, I think all of us, that we can control the diarrhea by, really educating, dose reducing, giving loperamide, all those things, Imodium. Any thoughts on that? How hard it is to control the diarrhea on abemaciclib?
No, I mean, I just say that with, over time, I've learned that you have to dose reduce fairly quickly. I mean, when someone, is tolerating terrible diarrhea, I mean, in the beginning, patients are often willing to suffer. And, for some patients, they might even have they might actually be like, great, it was great to lose 15 pounds. I needed to lose those 15 pounds. But then after that, it's, I really want to be able to, leave my house without having to wear Depends. And I want to be able to go out and have lunch with my friends without knowing where the bathroom is. And so I feel like just observing, people in the community, patients I see as second opinions, I feel like in the community, the oncologists, basically push patients very, very hard to stay on the full dose. And I'm pretty quick to drop, to 100 milligrams right away, 100 milligrams BID, because if the patient is, is unable to leave their home and can't eat what they want to eat, it's, what are we doing? What are we doing?
I agree. And sometimes I'll even go to 250, so 150 and 100.
Yeah.
I'm a big, strong proponent of having people take it, even a half a Imodium a day, and or if they're going out or taking, eating a green salad or something. I totally agree with you. It's all about, our quality of life and managing that. A lot of studies have shown that if you dose reduce for toxicity, that side effects, that the efficacy or the effectiveness remains the same. So that's good. And in terms of other studies that we have we're opening and have a few open already that are looking at new hormone drugs called selective estrogen receptor downregulators that are oral SERDs, and also other variants of that, some other kinds of endocrine therapy. And many of those trials, not all, are also have arms of the trial where they're continuing the CDK4/6 inhibitor and changing the endocrine therapy, or changing both of them, but using a CDK4/6 inhibitor partner. So we will have even more trials at UCSF that will be looking at this particular patient population. And then there's also Jo Chien's neoadjuvant program, where lots of people are working on it with her around the United States, looking at different combinations. You might just want to mention that briefly, Jo.
Yeah, we are looking at novel endocrine combinations for patients who we believe may benefit more from a hormone approach than a chemo approach. This is a sub-study within our I-SPY trial, which is it started out as a neoadjuvant chemo study, but we've identified a group of patients where there's risk because their tumors may be larger, their lymph nodes are positive. But when we do more, a deep dive in the biology of their tumor, we find that it's not really a chemosensitive tumor. And so we're doing it's an extension of I-SPY using oral SERDs, where it's like an oral version of Faslodex, for lack of a better way to explain it. These are drugs that downregulate the estrogen receptor. But Faslodex has limitations because it must be given intramuscularly. So there are pharmacokinetic limitations that we hope to get around by giving it orally. So we're studying that class, or that class of agents in combination with, one arm is abemaciclib, one is letrozole, and one is by itself. And we're giving it before surgery for 6 months.
Yeah, I think that's really important, and it really has to do with, pharmacokinetics has to do with how the drugs are cleared and metabolized in your body, and these drug interactions can be important. Plus, people don't like getting 2 shots in their butt once a month, so it's not comfortable. So that's a big issue.
Yeah.
Just before we go on to Destiny Breast 04, there's a question about why do people start at the highest dose of abemaciclib if they have a lot of diarrhea? And it is a question. I mean, I think if you think somebody's really high risk, you could start lower and increase. But a lot of people, we can control the diarrhea. I'm always surprised how many people are able to stay on 150 twice a day. So it's a hard thing. Do you dose reduce right away, or do you try and gradually dose escalate? And I think we all individualize it based on the patient. And it is a question, do you need that higher dose? But because the lower dose is effective in people who dose reduce, it probably has to do with metabolism. So we don't really know. I mean, there's a whole dose finding initiative, and these are really complicated questions, hard to know. Do you all start at 150 twice a day in general?
I do, except for, patients that are, kind of frail and already maybe very, very thin, who don't, again, have that weight to lose. I would say, is someone over age 75, who has a low body mass index, other comorbidities, someone who already, has some GI issues, that I start lower. I would start with 100 BID and try to work my way up.
So we were going to talk about, we'll go on from the hormone world. We have a few other things to talk about, some interesting trials. Hopefully we'll get to at least 2 or 3 more. But I think the trial without question that had the biggest press at ASCO was the plenary talk. And plenary are the best of the best. So the best presentations that are submitted by abstract to ASCO are selected for the plenary. And breast cancer is rarely in the plenary, and mainly because we have a lot of treatment options. But this made it to the plenary and then got a standing ovation. I think everybody was so excited. There was, there's always a rollover, an overfill room, and the standing ovation, I think, represented, the years of the pandemic and frustration and trying, really hard to improve the lives of our patients with metastatic hormone receptor positive breast cancer, in particular, the most common subset of breast cancer. And just in the, treating disease is hard, running these trials is hard, and having a trial that's a slam dunk is, I think, huge for all of us. So Laura will tell us a little bit about Destiny Breast 04.
Perfect. Let me share my screen, open it up. Perfect. Great. So I'm really excited to talk about this study, which, as Dr. Rugo mentioned, was really the highlight of ASCO from the breast cancer world. And so I think really important to share with you all. But first, I wanted to give a little bit of background about antibody drug conjugates, since some of you may have heard of these already, but they're a newer kid to the block. So I do think before we dive in, it's helpful to have some background. So antibody drug conjugates, we often call ADCs. So these are a novel class of anti-cancer medications that are composed of three parts. So first, they have a targeted antibody that helps the drug specifically bind to certain parts of the cancer cell. So it helps basically deliver the drug to the cancer cells as best as possible. And then secondly, they have a linker. And then finally, they have a cytotoxic part of the drug. So something like chemotherapy attached to them. So basically, it has the benefits of chemotherapy with the cytotoxic part, but in theory, it's a little bit more directed towards the cancer cells. So the antibody drug conjugate studied in this trial is called trastuzumab deruxtecan, or TDXD. And it's composed of an antibody directed towards HER2, as well as a linker, and then a payload, which in this case is a topoisomerase 1 inhibitor. And this drug was previously studied and deemed to be effective in patients with HER2 positive breast cancer. And so the question in this study is whether we can use the same drug in patients with lower levels of HER2 on the surface of their breast cancer cells, something that we call HER2 low breast cancer, which I'll explain here. Not advancing either. There we go. So a little bit of background about HER2 low breast cancer. So HER2 positive breast cancer is a subtype of breast cancer with overexpression of the HER2 protein on the surface of the breast cancer cells, which we confirm with two different tests. With one test called the immunohistochemistry test, and you have to have an IHC of 3+ to be positive, or you can be 2+, which is indeterminate, and then be positive for FISH. And so in contrast, the definition, so I wouldn't consider HER2 low as a distinct breast cancer subtype at this point. We really think this is just a definition that we've created for this particular study. And I think there's a lot more that we need to learn about how we define these patients. But for the purpose of this study and for the purpose of our what we're calling HER2 low right now, these are patients that have HER2 IHC of 1 or 2+, but with a FISH negative. So as I said, it's a heterogeneous population. Many of these patients are hormone receptor positive. Some of these patients are also triple negative. And so this study was enrolling both patients that were hormone receptor positive and triple negative. And so in terms of the study design, this slide depicts the study design. Patients were eligible to enroll if they had HER2 low breast cancer, which I just explained, and they had to have metastatic disease, and they had to have been treated with 1 to 2 prior lines of chemotherapy in the metastatic setting. Patients could be either, like I said, hormone receptor positive or triple negative, and patients who are hormone receptor positive also had to have progressed on prior lines of endocrine therapy. So upon enrollment, patients were randomized 2 to 1 to receive either the ADC TDXD every 3 weeks or chemotherapy of physician's choice, which in this case was capecitabine, eribulin, gemcitabine, paclitaxel, or nab-paclitaxel. And the primary endpoint of the study was progression-free survival in the hormone receptor positive group in particular. Basically PFS, just to back up, is how long the patient stays on the drug until their disease progresses. And the second endpoint was PFS across all patients, as well as overall survival, which is how long the patient survived after starting on treatment. Baseline characteristics between the two groups were relatively balanced. The median age was 55 to 58 years. Most of these patients were female. Most patients did have hormone receptor positive disease, although there were patients with triple negative disease as well. And about 70 to 75% of patients had liver mets, 30% had lung mets, and 5% of patients had brain metastases. And so, like I mentioned, the primary study endpoint is progression-free survival in the hormone receptor positive group. So as you can see here, in patients who had hormone receptor positive disease, those who received T-DXd had a PFS of 10.1 months versus those who received chemo only had a PFS of 5.4 months. So when you look at the separation between those curves, the difference is 4.7 months, meaning that those who received T-DXd were able to stay on the drug without progression almost 5 months longer than the other group, which in our world, seeing curves that separate this far apart is really, really impressive. So we were very exciting results. And then across all patients, including the triple negative patients here, there was also a similar really impressive benefit, 9.9 months versus 5.1 months in the patients that received chemotherapy. And then looking at the overall survival data, so we know patients can stay on the drug longer, but do they actually survive longer, which is obviously very important as well. And so as you can see at left here, the patients who had hormone receptor positive disease that received T-DXd did indeed survive longer than those who got the chemotherapy. So 23.9 months versus 17.5 months. So these patients lived, 6.5 months longer almost, which is, quite meaningful. Some of our trials, it's 1 month or 2 months. So having a 6.5 month improvement is quite impressive. And then across all patients, those that received T-DXd lived 23.4 months versus 16.8 months in those that received chemotherapy. So again, a difference of about 6.5 months, 6.6 months to be exact. And then looking across subgroups, so in this plot, basically, if you look at the dotted line here is, let's say they're even, over here to the left is favoring T-DXd, and over here to the right is favoring chemotherapy. And as you can see, all of these lines are on the left in the blue here. So across all of these subgroups, T-DXd was favored. So whether or not you were IHC 1+ or 2+, patient age, race, whether they had visceral disease, whether they'd received prior CDK4/6 inhibitor, in all of these groups, T-DXd was favored. And then in terms of side effects, patients who received T-DXd had more nausea than those that received chemotherapy. And patients who received chemo had more issues with low blood counts. And one particular thing that we're attuned to is that many of the ADCs cause inflammation of the lung, or something called interstitial lung disease or pneumonitis or other names for these. So it was a particular interest here to see if that was an issue. And so in this study, 12.1% of patients who received T-DXd had some degree of lung inflammation or pneumonitis versus only 0.6% in the chemo group. And unfortunately, there were 3 drug-related deaths in the T-DXd group that were attributed to this lung inflammation. I think now that we better understand and recognize this lung inflammation as a risk, I think we're getting better at recognizing it early, stopping the drug, treating it with steroids. But I definitely think this is a side effect that's important for patients and providers to be aware of so that we can catch it early and avoid these more serious problems. So thus, in conclusion, the authors demonstrated that T-DXd is the first HER2-targeted therapy to have a statistically significant and clinically meaningful improvement in outcomes for patients with HER2-low breast cancer. And the benefit was seen, like I said, across all subgroups. The safety profile was consistent with those previously demonstrated with this drug in the HER2-positive space, with ILD or interstitial lung disease being a really important toxicity to be aware of. So I think in terms of thinking about, what are issues where does this lead us in the future? I think, this is a very, very exciting study. This is a drug that is really going to benefit many of our patients. Not only do people, are they able to stay on the therapy longer, but they actually live almost 6 months longer, which almost anyone would argue is a huge improvement. It does raise a lot of questions. I think one of the main questions it raises for me is, what is HER2-low breast cancer? Like I said before, we defined it here with an IHC of 1 or 2+, but I think we need a better biologic understanding, because there's a number of studies that show if you ask one pathologist, they might say it's HER2 0, another pathologist might say it's HER2 1+. And so, we shouldn't be that different pathologists would read it differently. Is there a better way to define this that's less subjective and more biologically based? So I think that's a really important thing moving forward. I think another question is, will this drug work in cases of IHC 0, which is going to be studied in the future, being studied now, which was not addressed in this particular study. It also raises a lot of questions of drug sequencing. So for example, if a patient now gets TDXD, the therapy they get next, will that be as effective, especially if they get other antibody drug conjugates that have similar payloads or similar, antibodies rather, are they going to be as effective? So I think the sequencing of drugs is a question that's always an issue. If we're moving this earlier line, how is that going to affect things down the line? I also think, should we be thinking about using this drug earlier in the early stage breast cancer setting, which is also currently being studied? Third, I think we need to better understand the mechanisms of resistance. So how are these cancers eventually outsmarting this drug? Can we add any components to basically prolong its efficacy? So that's always important to understand as well. And then finally, I mentioned the drug-related lung disease. So can we predict which patients are at higher risk for this? Can we improve efforts to detect it earlier and prevent severe cases? So I think these are all questions that we'll think about in the future. So all in all, I think really, really exciting data and a great option for our patients with both hormone receptor positive and triple negative disease who have this HER2 low categorization right now. I do think we need to define that better, but much really, really exciting to have this to offer our patients.
Yeah, I mean, this was really such an incredibly exciting study to see that we could improve both progression-free and overall survival in patients who have hormone receptor positive disease. I think it does still remain to be seen whether or not it matters at all if you have HER2 that we can detect. As you mentioned, and I think nicely outlined, it's really unclear. And there was a study looking at some samples in patients who were HER2 0, but had patchy HER2 across the tumor. It's just, nothing ever has been designed to see if you have a little bit. And the tests aren't designed that way. So we don't know. And, I have treated a couple of patients with TDXD on our trials who had hormone receptor positive HER2 negative disease who had no response at all. So it's never a universal fix. But certainly this is interesting, and moving the drug earlier, being aware of the pneumonitis risk, all really helpful. One of the questions that I have just in terms of sequencing is for you, how would you sequence this now? Would you give it, the median number of lines of therapy was 1. So would you give it in the second line setting? That means after you've already had 1 treatment.
I mean, I think that the data is compelling enough. The benefit's quite large, and it was studied here with 1 to 2 prior lines, the median of 1. So I do think we're going to be using this in the second line setting after 1 prior line based on this data. I think the question is, are we going to even be using this in the first line, which is not studied here, but will be studied shortly. But I do think we will use it in the second line based on this data.
Yeah, and when somebody asked if it's available for patients, it's already approved. This drug is approved for the treatment of HER2 positive breast cancer, where it beat TDM1, the antibody drug conjugate that was in that place before. We put it into the National Comprehensive Cancer Network guidelines a week after ASCO. I mean, I think the presentation was on Sunday, and within 8, 9, 10 days, it was already in the NCCN guidelines. So there was an immediate phone call, and we all talked about it. So that's good. There's also another antibody drug conjugate, I don't know that we're going to get to today, sacituzumab govitecan, where there was benefit in hormone receptor positive disease without the HER2 status included. So but the study population was more heavily pretreated, and so it's a little bit later line data and a little bit less dramatic, I would say, compared to the Destiny Breast 04. So, but the drug is available. It's just, and we've certainly given it to patients already, and it's an important sequenced drug to be available for patients after 1 or 2 lines of chemotherapy. Really an important one. But what about Michelle, what is your sort of take on the 58 patients with triple negative disease? We have seen sacituzumab govitecan and show improved progression-free and overall survival in a randomized phase 3 trial, but patients who were more heavily pretreated.
Yeah, I mean, I think that was the point, and I was going to kind of ask you the question. You got the question to me that I was going to ask, is that, yeah, I think that unfortunately, the TROPICS 2 data did not, get as much hype because, people were so excited about this. But I do ask myself, for patients that are, ER positive and HER2 low 1+, these both have a payload that's a topoisomerase 2 inhibitor. And so what is the right thing to do for someone that has, let's start with the ER negative HER2 1, score of 1, am I going to, suddenly say that, patients that are triple, so-called triple negative, but they're, ER negative, now HER2 low, should get this over, over sacituzumab govitecan? And I don't know the answer. I think what has been driving most of my patients' decisions when I present it is the 3-week dosing versus the 2-week on and 1 week off, honestly. The other factor is, of course, hair loss that, with sacituzumab govitecan, it's almost, 100% of patients have lost their hair. And in my experience, N of 2 of patients that have tried to use cold caps with sacituzumab govitecan, it hasn't gone so well. These antibody drug conjugates probably have a longer circulating, they have a longer circulating half-life. So that's really been driving the decision. It gets
patients where cold caps worked. I just want to say.
Yeah, you did. Okay. I mean, I said N of 2, N of 2,
yeah.
But then I think it, with the, with trastuzumab deruxtecan, if you have someone who has pulmonary disease, I think it is tricky if you have someone who already has, let's say, lymphogenic spread in the lungs, and they're already short of breath or they already have a cough. It's going to be quite hard to tell what is the disease and what might be ILD. And so those people, I might lean more towards using sacituzumab.
Yeah, it is hard. You have a big group of patients, and certainly if we give sacituzumab or Trodelvy earlier in the course of disease, we see less toxicity, but you do have to come in 2 weeks on, 1 week off. But we have a lot more data than we do. And plus, it doesn't matter what the HER2 is. Joe, do you have different thoughts about that, or do you do pretty much the same thing?
For the triple negative patients, I with the 50 some patients in Breast Destiny 04, I think it's just such a small population. I lean towards the sacituzumab first for the triple negative patients. To be honest, I'm going to use both, right? And so I do think the data right now is stronger for sacituzumab in triple negative specifically, just given that it's a small subset in Breast Destiny 04. I agree with you that there are some inconveniences as well as toxicities associated with sacituzumab that would make the trastuzumab deruxtecan more attractive earlier on. But right now, I'm starting with the SASI and then moving to the deruxtecan afterwards.
Yeah, it's interesting about the ILD pneumonitis. I've struggled with some patients who are on Destiny Breast 04, where you see ground glass opacities, this sort of haziness on the chest CT, and they have no symptoms. And at that point, you're supposed to hold the drug and give steroids, and then it goes away, and then you treat again, and sometimes you dose reduce, and then it comes back. And I had one patient who, we sort of did this from November until I think April, when she got short of breath, and I had to stop it permanently, and she did get better. We luckily haven't had anybody come even close to needing to be on a ventilator, knock on wood, or dying of this side effect. And I think it's really a tribute to the tremendous detail that our providers in our practice take and how careful we are about managing symptoms. I think our nurses, nurse practitioners, and physicians are really, really careful about this and take care of patients following the guidelines and with a lot of detail. But still, it's something you have to keep track of and not wait 6 months to do your scans and wait for symptoms.
Yeah, I mean, I really do worry to some degree of what's going to happen in the community when this drug is let loose, in that, on the trials, patients are getting scans at intervals of, 6, 8 weeks. And if someone is going to be stable, some of these patients, particularly with HER2 positive disease, so we're getting, this for HER2 positive breast cancer, if someone's been stable for 2 years, as I've seen on this agent, your inclination is to want to spread the scans out, and then, and people are doing well. And so you don't see them as much, and they're not talking about it. And so I do worry that, we have to keep sending a message to people who haven't had experience with it in trials, that they have to, be more diligent.
Yeah, I think
And based on some of the data that I've seen, and correct me if I'm wrong, but the curve for when it presents itself kind of plateaus after, a year to 2 years, right? So it's not that there's necessarily a cumulative effect that continues, which is somewhat reassuring.
No, I think that's a really important point. In the Destiny, the only place we've seen that so far is from Destiny Breast 01, which is the phase 1b trial, where all of the cases but one occurred in the first year. These were patients who had more heavily pretreated disease, so the little more cancer instability that first year, but it was all but one was in the first year. That's the one that occurred at 18 months was a fatal event. So it still needs to be followed, since we really don't like that at all, any of us, patients and providers alike. But so I think you can't, I've been thinking you really shouldn't do scans any less frequently than every 9 to 12 weeks in the first year. And then you could maybe go out a little bit in the second year, but keeping in mind that if you have a cough, you can't just say, oh, I have a cold, you just have to be really on top of that and be aware of it. It's, giving sacituzumab or Trodelvy earlier, also for triple negative disease, you get less toxicity. So, less side effects. And that's true of all of these. So for hormone receptor positive patients, would you move this ahead of any endocrine therapy options? Would you give it first line in a specific situation or for a specific patient?
I don't think I'm moving it that early. I mean, it is still chemotherapy. I mean, it's, people, people are like, oh, it's an antibody drug conjugate, or they hear that it's an antibody, so they think it's an immunotherapy. I mean, it's still a chemotherapy. They want, you call it, I don't know why they think it's better to call it a toxin than a chemo. I don't think that sounds worse to me. It's an antibody bound to a toxin.
A payload.
A payload. Yeah, if we call it a payload, that sounds better. Like people are getting paid to take this. But no, I mean, it's not, I'm not going to move this up for, in front of endocrine therapy. I think the big question for me really is, for patients, like our usual pattern of, hormone therapy, go through a couple lines of endocrine therapy, then, they may get Xeloda, which is often our pattern of moving into, Xeloda, and to transition into chemotherapy. And then where does this fit as compared to taxanes? And I still, it's so like, this drug is so good that you kind of want to hold it, you want to kind of hold it. And I mean, I know other people don't, but I think there is this question, taxanes are very well tolerated, very little nausea, other than the hair loss. And, if someone's on it long enough, the neuropathy, I think that the quality of life with, a taxane is quite good. And so I wonder, which patients I'll select this over moving to taxane as the first line therapy for, chemo. I'm not quite sure I'm going to.
We've given capecitabine in hormone receptor positive breast cancer patients in the first line setting. So
yeah. That's, I should say first line infusional chemotherapy. Yeah, sorry.
We do have a trial that's allowing capecitabine as one of the chemo options in the first line chemotherapy setting, where you test the cancer to see if it has an immune marker called PD-L1 for hormone receptor positive disease. And it even has a score of 1. You can be randomized to either get Keytruda, the pembrolizumab checkpoint inhibitor, or not, with a choice of chemotherapy as first line treatment. So that's one, I think, kind of cool option that's being studied for patients. I think one of the things that's come up is if you had a patient who had very hormone resistant cancer, so cancer doesn't respond at all to hormone therapy and has a lot of lung or liver involvement, would you consider moving it earlier in the course of treatment?
Yeah, I would absolutely. I mean, I think capecitabine is still a very attractive option in the first line just because it's oral and there's no hair loss. And from a quality of life standpoint, I think it's a very good option. So, but like anything, right, like these very resistant tumors, we have to go outside the box of standard treatment, because if they're resistant to their original neoadjuvant or adjuvant chemotherapy, then likely they will be more resistant to our traditional chemos, and going into an antibody drug conjugate earlier would make sense. Especially these tumors, now that we're giving abemaciclib in the adjuvant setting, these high risk, more aggressive resistant tumors may recur on or soon thereafter abemaciclib. And so in those patients, it might be that you get an antibody drug conjugate sooner if you don't, start with a CDK4/6 inhibitor in the metastatic setting.
That's a good point. And then just in terms of going back to what Michelle was saying, this is chemo, even though it's called an antibody drug conjugate, is that the primary toxicity of this drug is not ILD, which is, happens in somewhere between 10 to 15% of patients, but is very, very rarely fatal, and hopefully never in our patients. But the primary toxicity is nausea, and it is a big deal for some patients. They get late nausea, people are nauseated on and off. It's funny, some of my patients just sail through no problems, and others have lots and lots of nausea. So it is important to manage that and think about how to manage it. So it's really been fascinating, and I think we will end up being able to, I think in our next session, which we'll have in September, carry over some of these topics that we have. We'll talk about sacituzumab govitecan from the TROPICS trial, and we'll talk about cell-free DNA, a really fascinating study that Laura presented looking at a subtype of patients with hormone receptor positive breast cancer who are particularly sensitive to chemotherapy and immunotherapy. Really, really important as we look forward to trying personalized therapy. But in our last few minutes, I thought maybe Michelle could very briefly, talk about a study in where we've been thinking about whether or not we could do special treatments for patients who have limited metastatic disease, so-called oligometastatic disease.
Yes. And so, for the sake of time, I can share my slides, but I will just start talking right away. So there was, there's been an interest in, as we do more studies and more patients that have early stage disease are actually undergo scanning, we are definitely finding more patients with oligometastatic breast cancer, meaning that when they, when they are diagnosed, they have, only 1 or 2 metastases. And there's been an interest in, knowing whether doing, more aggressive treatment to these focal areas of metastasis along with systemic therapy might improve outcomes. And so this term that we use when patients have oligometastatic disease, it's defined in different ways, but in this particular trial that was presented at ASCO, the NRG BR02 study, they defined it as patients that had limited breast cancer with less than or equal to 4 metastases. And there was a previous study called the SABR Comet trial, which was a mix of different tumor types, not just breast cancer, but non-small cell lung cancer, other tumors, solid tumors, where they actually used SBRT, or this type of stereotactic ablative radiotherapy, to patients that had oligometastatic disease, and they actually saw improvement and survival, as you can see here. And so, and it was also, manageable, but they did actually have 4.5% grade 5 toxicity, which means death. So this trial randomized patients who were, again, had oligometastatic breast cancer, who had been on systemic therapy without progression for less than or equal to 12 months, were randomized to get standard systemic therapy or ablation to all the metastatic sites that they had. And you can see on the right side, the target accrual. They did a phase 2 randomized of 128 patients, and the plan was a total phase 3 of 360. And they excluded patients with brain metastasis. I always like to bring that up. And they randomized patients or stratified patients according to a number of factors, including only having 1 distant metastasis versus more than 1, whether they had received chemotherapy for metastatic breast cancer. And they actually tried, they were very, very detail oriented in the type and the dose of biological, the dose of radiation that they gave. So to make sure that, patients that got radiation got a very, very powerful and ablative dose. For the sake of time, I'm going to skip over this, except to say that the majority of the patients in this study, 80% or more, about 80%, had a hormone receptor positive HER2 negative breast cancer, as you can see here, and 60% had only one metastasis. Although there was, you can see 40% that had greater than one metastasis. And just again, for the sake of time, you can see that only about 28% of patients had had prior chemotherapy. The majority of them had had prior hormonal therapy. And here is, unfortunately, the data that was presented. I say this unfortunately because it turned out to be a negative study. That the SOC stands for standard of care, meaning the systemic therapy, and a standard of care plus A means the ablative radiotherapy. And they were looking at progression-free survival, and they did not see a statistically significant difference. So giving patients radiation to the focal radiation, ablative radiation to these metastatic sites did not improve progression-free survival. And similarly, they did look at various subsets, and for the sake of time, my slide is not moving forward, but unfortunately, they tried to look at different characteristics to find out if there were certain subsets of groups that did benefit. Again, because of the size of the study, they weren't able to really find many differences. But unfortunately, this trial was not what we had expected to find, and we were hopeful that we would see improvement, because this has been, after the Saber Comet study, has been a paradigm that we have been following, referring many of our patients. But I just, because of the sake of time, I'd love to talk more about this, but I wanted to just ask Hope and others on this group how they reacted to this data and what they thought it would change, if it will change our practice, particularly since this was really focused on ER positive, HER2 negative patients, where we often will have someone with HER2 positive breast cancer that might have one metastatic site, and we know those patients have very, very chemosensitive disease.
Yeah, I mean, I think that it's so interesting in this study. So the whole idea being that if you have, you walk in the door with a few metastases, or you have recurrent disease to a limited number of spots, you could, use treatment that works and then zap the remaining tumors, right? And now we can do this really focal radiation, so it's feasible, right? So-called SBRT, or selective brachyradiotherapy. But they used this definition where you had so many lesions, and then they included everybody, where it's probably only going to benefit a small number of patients or a specific tumor biology. So I kind of thought, great that they were able to do this study, really, really good work, but it doesn't help me a lot.
Yeah, I mean, because I think it really, for, especially when there's a population that we see in this population that we want to be aggressive and do this for, are those patients with de novo stage 4 cancer, where we have an opportunity to treat with systemic therapy, and see how they respond. And those patients that, have extremely responsive disease, where we know that, for example, if they have an intact breast, that is something, that if they respond very well there, that they would probably benefit from this kind of ablative therapy. But if someone has very resistant disease from the get-go, radiating 4 spots is not going to make a difference.
Yeah, I think that's a good point. Anybody else? Is our patients you still might treat this way?
Yeah, I mean, I think survival isn't necessarily the only endpoint that drives this decision. I think that the time to, that you stay on hormone therapy, or sort of the time to needing to make a change, or the time to starting chemotherapy, are very meaningful endpoints for this population. So I, in select populations, would still pursue this aggressive strategy, especially in patients where I think some of these other sites, and including the primary breast, is going to be the first place of progression. And if I can kind of either take care of that with, whether that's SBRT or surgery to the breast, which is a different question, different trial, that can sometimes extend the amount of time they can stay on first-line endocrine therapy with the CDK4/6 inhibitor, and that's meaningful to the patient.
Yeah. Yeah, the time to progression, I mean, the PFS was not, what we would have hoped. I mean, I think in general was shorter than what we might have hoped for someone. So yeah, it was a lot of mix up in the trial in terms of the patient population. So it's not perfect, but it does. I think one of the messages, though, the takeaway is that, I also think we shouldn't be just randomly radiating various spots with the expectation that it's going to extend survival. I think we, certainly if someone has a painful metastasis, I mean, again, I don't want to keep sort of mentioning what I see in the community and criticizing it, but I do often see, patients will have, site of progression after site of progression in the bone, and they just keep getting sent back to the radiation oncologist to get another spot radiation, another spot radiation, another spot radiation. And I think that does them a disservice in the long run, because then, their bone marrow has been, radiated a lot, which is something we want to avoid for long term when people need that marrow reserve.
Yeah, I think the point that Michelle's making is really important, which is that just, radiating something because it's there doesn't really help, and it actually can hurt. I mean, we've seen patients who have do very, very well with their cancer, who've got a lot of radiation to spinal lesion, for example, that sometimes the integrity of the vertebra is affected over many years, and that can result in the need for surgery or other issues. And then we rely, of course, on the bone marrow to make our blood cells. And if you radiate a lot of the bone marrow, sometimes the bone marrow is not quite as healthy, and you end up with having trouble tolerating chemotherapy. So I think that, then there are other side effects that can occur, we all know, from radiation. So, we want to use the treatment judiciously. I think this is a really important discussion and topic that you brought up, and all of the topics we talked about were great. We had some really fabulous discussion as well, and we love the questions that came in. And I think there's one little last one in there, but with somebody having a question. And I think that there are a lot of different ways of managing oligometastatic disease, so to speak. And there clearly is not any one right way, except for that we shouldn't be radiating lots and lots of tumors. And continuing the systemic treatment is important, as the question notes here in our Q&A box. And the other topics are great too. We have some other really important topics. We just didn't have time to get to them. And I thought it was more important that we really talk about the data we were presenting. So I hope that the audience will come back, and our speakers towards the end of September for our next session, where we'll be able to talk about some topics like cell-free DNA in the early stage setting, and others, which I think the work that Laura Huppert presented, and we'll talk more about the sacituzumab govitecan TROPICS trial, et cetera. And I think other data as well, because when we meet next, it will be after the European Society of Medical Oncology meetings, which also will have some interesting presentations that we'll be able to talk about as well. And, there's a lot about hearing a presentation that is interesting, but that's 10 minutes. And talking about it together and thinking about how we incorporate this data into the clinic is really the most important part. And we appreciate your participation, your questions, and also Melody Galu's amazing work. And of course, for my colleagues, giving up their evening to talk to all of you is an incredibly gracious and wonderful thing to do. And why working at UCSF is such a great place, because we have a wonderful group of people. So thank you very much. And we'll see you after the summer. Enjoy the rest of your summer.